Hi everyone, I am Dr. Shailee. I am consultant and head of department emergency in Moolchand Hospital. I am here with a topic benzodiazepine toxicity. So coming to the basic anatomy of benzodiazepine, what is a benzodiazepine? The term benzodiazepine refers to the portion of the structure composed of a benzene ring fused to a seven-member diazepine ring and a phenyl ring attached to the five position of the diazepine ring. I know this is the basic anatomy. We don't need to research about it. So this is the basic structure of benzodiazepine. And whenever the specific positions of the diazepine ring is changed, we get different forms of the benzodiazepines. Pathophysiology. So what do benzodiazepines do? Benzodiazepines, they basically bind to the GABA A receptors. And as we know, GABA A receptors are basically the inhibitory receptors. To these receptors bind GABA. What are GABAs? These are inhibitory neurotransmitters produced by the presynaptic membrane, right? So whenever these inhibitory neurotransmitters bind to the receptor, they give signals to suppress the further action of the cell. So these benzodiazepines, these bind to the GABA A receptors, these enhance the activity of the receptors and they cause effects. So what they do is, these benzodiazepines potentiates the effects of GABA on chloride channel, increasing hyperpolarization. What does this mean? This means when benzodiazepines bind to these receptors, the chloride channels, these open up and there is influx of the chloride ion from extracellular compartment to the intracellular compartment. And as we know, what does chloride ions do? Chloride ions, these inhibit the action of the cell. This causes hyperpolarization and it has inhibitory effects on the cell. So the GABA effects, when these GABA acts on limbic system, it affects the mood, it alters the mood, it causes drowsiness and also muscle relaxation. So benzodiazepine exert their action by potentiating the activity of GABA. They bind to a specific receptor on the GABA A receptor complex, which facilitates the binding of GABA to its specific receptor site. Now, benzodiazepine binding causes increased frequency of opening of the chloride channel. As I explained earlier, it causes opening of the chloride channel complexed with the GABA A receptor. Now, chloride channel opening results in membrane hyperpolarization, which inhibits cellular excitation. This is the basic diagram. These are the receptors. These are the basic receptors. And when benzodiazepine binds to these receptors, it causes opening of the channel for the chloride ions. So the chloride ions move from outside cellular compartment to the inside cellular compartment, inhibiting the action of the cell. Same diagram. In the presence of benzodiazepine, influx of chloride ion increases. More chloride ions enter the cell, inhibiting the function. So enhanced GABA neurotransmission results in sedation, striated muscle relaxation, anxiolysis, and anticonvulsant effects. Stimulation of peripheral nervous system, GABA receptors may cause decreased cardiac contractility and vasodilatation. So these changes could have the potential to alter tissue perfusion. Also, these can cause bradycardia, these can cause hypotension. Coming to classification of benzodiazepines, there are long-acting benzodiazepines which act for 1 to 3 days, intermediate-acting benzodiazepines lasting for 16 hours, or short-acting lasting for 3 to 8 hours. So the long-acting benzodiazepines, mainly we have to know about diazepam. Intermediate-acting benzodiazepines, lorazepam, and short-acting oxazepam. So benzodiazepines are metabolized predominantly in the liver by oxidation via conjugation. Most benzodiazepines are broken down into pharmacologically active metabolites which may have longer half-lives than the parent compounds. The rate of benzodiazepine onset of action is determined by its ability to cross the blood-brain barrier. The relatively lipophilic benzodiazepines usually produce a faster onset of effect than the relatively water-soluble benzodiazepines because these can easily cross the blood-brain barrier, being lipophilic. Benzodiazepines effects can be potentiated when ethanol is present as a co-ingestant. Peak blood concentrations of most agents occur within 1 to 3 hours. After a single dose, the lipophilic agents can have a shorter duration of action. Shorter CNS effect means than water-soluble agents because rapid redistribution from the CNS to peripheral sites, example adipose tissue occurs. What does this mean? This means if the agent is lipophilic, it will easily cross the blood-brain barrier. It will have more CNS effect, but the effect will last for a short duration because it is taken out of the brain and it is distributed in the adipose tissue at the very same rate, being lipophilic. Thus, lorazepam, which is water soluble, has a longer CNS duration of action than diazepam because lorazepam is water soluble, though it enters slowly, but its effects last longer because the distribution is impaired. However, diazepam metabolizes to active intermediates with prolonged half-life, extending its therapeutic effects. Now, coming to signs and symptoms. The signs and symptoms are rapid, with most developing symptoms within 4 hours. So the patients initially present with mild to moderate impairment of CNS function because it's basically acts on the CNS. So the patient will present to us with somnolence, diplopia, impaired balance, impaired motor function, anterograde amnesia, ataxia, or slurred speech. Sometimes paradoxical reactions such as anxiety, delirium, hallucinations, and aggressions also occur in such patients. So this is a diagram explaining about the basic signs and symptoms. So patient will come to us with history of ingestion of benzodiazepines in overdose, and he will come to us in drowsy state. He will be hallucinating. He will be not able to respond or talk. He will be dizzy, confused, drowsy, with respiratory depression as well, along with weakness, low blood pressure. So these are the basic signs and symptoms of the patient. So what do we see is, so it's basically a clinical diagnosis. The patient will have history of overdose and the patient will have clinical symptoms. So we have to catch these points. Also, the patient will present to us with GI symptoms like nausea or vomiting. Sometimes overdose can cause deep coma, apnea, respiratory depression, hypothermia, hypertension, bradycardia or arrest, or sometimes pulmonary aspiration as well. Symptoms such as sleepiness, agitation, and ataxia occur much more frequently and severely in children. Hypotonia may also occur, especially in children. Now, coming to toxicity. So, benzodiazepines have a wide therapeutic index and taken alone in overdose rarely causes severe complications or fatalities. Taken in overdose in combination with alcohol, barbiturates, opioids, TCAs, etc., are particularly dangerous because these increase the penetration in the CNS and these cause more severe effects. In case of alcohol and barbiturates, not only do these additive effect, but they also increase the binding affinity of benzodiazepines to the benzodiazepine binding site, which results in very significant potentiation of the CNS and respiratory depressant effects. What does this mean? It means these additive agents, what does they do? They potentiate the binding of benzodiazepine to the binding sites. These increase the affinity of the benzodiazepine to their sites and potentiating the effect of benzodiazepines, causing more CNS and respiratory effects. Elderly and those with chronic illness are much more vulnerable to lethal overdose with benzodiazepines. A benzodiazepine overdose related coma may be characterized by an alpha pattern in EEG. How we diagnose? It's basically a clinical diagnosis. Patient will come to us with history of overdose. Obtaining a lab test for diazepam blood concentrations can be useful in patients presenting with CNS depression or coma of unknown origin. Basically, we have to send lab tests to see the level of diazepam in the blood. So what techniques do we use? We use thin layer chromatography, gas liquid chromatography, or radioimmunoassay. Coming to the treatment part, what do we do in emergency? In emergency, our basic goal is ABCDE approach. Right? So when a patient comes to us with clinical history of overdose and presenting within 1 hour of ingestion, our main goal is to do decontamination. What do we do if within 1 hour the patient comes to us? We have to do gastric lavage or whole bowel irrigation as recommended, right? Enhancing elimination of the drug with hemodialysis, hemoperfusion, or forced diuresis is unlikely to be beneficial. Why? Because these drugs are lipid soluble, and those drugs which are lipid soluble, it's very difficult for this technique to be used to clear the medicine. All right, so we cannot rely on hemodialysis. Or within 1 hour we can use activated charcoal as well. Basic ABCD approach. If the patient is comatose, if he is in respiratory depression or pulmonary aspiration, we have to take care of the airway and breathing. So we have to think of early intubation with artificial ventilation. This also affects the blood pressure. It can cause bradycardia as well in severe overdoses. So we have to take care of the blood pressure. How do we correct blood pressure? With IV fluids or with catecholamines like norepinephrine or dopamine. Bradycardia is treated with atropine or an infusion of norepinephrine to increase coronary blood flow and heart rate. So what are we doing? We are taking care of A, B, C. A, intubation, B, oxygenation, and then C, IV fluids or inotropes, along with care of decontamination part. Coming to flumazenil. What is flumazenil? It's the basic antidote. Flumazenil is a competitive benzodiazepine receptor antagonist that can be used as an antidote for benzodiazepine overdose. It abolishes the hypnogenic, psychomotor, cognitive, and EG effects of benzodiazepines. It should never be used orally. It has oral bioavailability of only 16%. So we use in IV injection form. On IV injection, action starts within seconds and lasts for 1 to 2 hours. Elimination half-life is 1 hour due to rapid hepatic clearance. What are the adverse effects of flumazenil? It can cause agitation, confusion, anxiety, tremor, withdrawal, etc. And the dose is 0.2 milligrams per minute injected IV till the patient regains consciousness. We have to give this till the patient regains consciousness. And what are the contraindications? We should not use benzodiazepines in patients who are on long-term benzodiazepines, those who have ingested a substance that lowers the seizure threshold because this can trigger seizure. Patients who have tachycardia, patients with white QRS complex on ECG, patients with anticholinergic signs or history of seizures. So what are the basic ED protocols for a patient coming to us with history of benzodiazepine overdose? We have to basically think about decontamination techniques. We have to think of ABCD approach, and we have to think of this antidote. So that's the summary of benzodiazepine toxicity. Hope it's helpful for you. Thank you so much.